All right, so thank you everyone for coming. Everyone who's familiar with our series knows that these are part of the Aerolib Learning Management series, and then we'll talk about some topics that we've already covered, and then what's new in December and what's coming along. But today's topic is a pretty vast topic of clinical and regulatory review for chest pain. So people who have access to the learning management system can go to aerolib.com. When you scroll down, the box for Aerolib LMS shows up. Clicking on it will take you to your login page that's been assigned to each user. And then when you open up, it opens up a dashboard like this, where a lot of topics, your progress, your gamification points, what new topics are there, some recommended courses. Clicking on any one of these courses will open up another page where you have videos, references, PowerPoint slides. There's a lot of reporting that we do for some of the hospitals, and whoever has manager accounts can actually look in to see what their physicians have looked at, what their providers have looked at. In addition, there's the free Aorta app that can be downloaded on your Android phones, your iPhones. We had more than 90,000 views with about 150 members, each talking about new regulatory requirements. So sort of a forum in your hand. What we have done so far have covered a lot of topics for clinical and regulatory review. So we've done COPD, sepsis, acute kidney injury, pneumonia, CHF, seizures, abdominal pain, TIA, syncope, atrial arrhythmias. And what we do in these topics is, cover the clinical aspects, evidence-based medicine, but also guide you on how the 2 midnight rule, what the spectrum of regulators are, what are the red flags in documentation, helping you with secondary diagnosis, comorbid conditions, major comorbid conditions, and then pearls and tips. And the whole idea of this education is to avoid setting off audit red flags. So these were some of the topics. We've also have more topics that are listed on the slide for respiratory failure, case analysis. Now, these are not the clinical regulatory review, but these are things that physician advisors and providers and hospital admin should know. There's a beautiful one on 3D mapping of clinical data to improve clinical documentation. The Moon notice, condition code 44s, and then the value proposition of a physician advisor program. These are the new topics that we're doing today. We're doing chest pain today with the UTI last 2 weeks ago. There are new topics on MACRA, MIPS, hierarchical condition codes. And what I'd like to share is we have collaborated with the Healthcare Conference Administrators, the same company that sponsors the 4th National Physician Advisor and UR Bootcamp. We were also sponsors in San Antonio in July. They have shared with us their 3 best videos that are now part of the Aerolib LMS. So the first one is a former ALJ, Bob Soltis, and this is a ALJ mock hearing with some attorneys and physicians, and this is just a beautiful piece to know what actually happens when you're doing a discussion with ALJ. Now there are 2 other sessions for denial prevention, where a panel of speakers talks about who are the specific pairs and what the plan of attack is. And in session 2, it is when do you do peer-to-peers, how do you do it? Again, some national level speakers. We always start off with the disclaimer, telling you that CPT is not ours. It belongs to the AMA. Interqual, it belongs to McKesson. And so when we refer to them, we're sharing what they're saying, what pertains to our cases. All of you familiar with our series know we always start off with the spectrum of auditors, and you can see the traffic colored lights. The bottom 2, the greens, are the QIOs and certs, and these are actually our friends. They help with routine compliance. The middle yellow ones are the MACs, MICs, and RACs, and these are compliance oversight organizations. These are who refer us to the top 3 legal oversights, so the DOJ, OIG, and ZPIC. These are where payment issues are concerned, or where there is a fraud issue that's in case, and we always need to be very careful on that we don't get onto their radar screens. Now, when the RAC demonstration project started a long time back, the idea was to detect and correct past improper payments. And the other objective was to prevent future improper payments. So this is more than a 200-page report that they came out in June 2008, still very valid in this day. The reason I say that is you see number 4, that is the improper payment amount for the DRG 143 or chest pain, and that's where our topic is today. So we have covered heart failure, we've covered COPD, but the top 4, as you can see, are cardiac related. So the number 1, where there was $64 million in payment issues, was cardiac defibrillators, and chest pain is on the 4th, and that's the reason why it's important that we educate our providers on what to write and how do you write it. Now, having said all that, the introduction of the MIPS and the APM models as part of MACRA has a lot of quality metrics that they want in order to preserve payments. And so when it starts, in 2017 is base collection year for payments or effective payments that will happen in 2019, you can see there is going to be an initial 4% cut or raise as up to 9%. And this goes on till 2022 onwards until changes are happening. The 4 components of these MIPS, includes quality, resource use, clinical practice improvement activities, and then meaningful use of certified EHR technology, where what we are doing through the LMS actually comes in quality, documentation, clinical practice. So there's an overlap on what the LMS offers. Again, resource use is the use of value-based testing and imaging, and that becomes part of the clinical and regulatory reviews. So what CMS has introduced in the last few years and going forward for the future, again, is MACRA, MAPS, MIPS, and APM. They have these next generation ACOs, the Comprehensive Primary Care Plus programs, and chronic care management. Now, why I'm mentioning all this is when we talk about disease-specific documentation education, once you have that documentation as a rock-solid part of the medical record, all these value-based incentive programs start to make sense. Now, when I've done auditing for many years, and what we're actually looking for is, are the services that are being provided in the hospital, are they reasonable? And then are they medically necessary? Now, do they meet professional standards of care? And can they be given in another setting, which is always the question. Are you providing something that can be given in a nursing home? Do you need to occupy an inpatient hospital bed? So having said all that, let's start with chest pain, and people familiar with our disease-specific documentation education program know that we start off with some basics of the clinical disease, and then talk about where the secondary diagnosis, ICD-9, STEN, screening tools, and then what the coding tips are, and then what do we need to watch out as providers. So as I discussed in the previous slide when I talked about the introduction of the RAC program, CMS has paid about $19.9 billion in errors for Medicare fee-for-service claims. Now, all the numbers in the red, these are where I want to focus. So 17% were due to medically unnecessary services, little less than half was due to insufficient documentation, and then 41% of admission errors were one-day stays that were billed as inpatient. This is a very hot topic in the QIO world right now. But why we are doing the topic of chest pain is DRG 143 was one of the most common billing errors. And we'll talk about what observation, what inpatient, what are the documentation errors that happened, and what we can do to prevent them. Now, the issue with chest pain is that the location can be in any place that can mimic a cardiac event. And then, the image that you see, it pretty much covers the entire anterior and posterior thorax way down to the arms. We have about 6 million ER visits for chest pain, and approximately 12 to 15% are due to acute coronary syndrome, which means that about 85 to 88% are due to non-coronary issues. Now, what we look for is EKG findings, but when we look at the massive differential, These could be a cardiac, pulmonary, vascular, neural, musculoskeletal, and then there's this emotional component of anxiety and depression mimicking chest pain. And that's where the problem happens, is a lot of patients that present with chest pain, unless we do an adequate history and physical, unless we do risk stratification for the comorbid factors, it's very difficult to predict whether this patient is having an acute MI or whether this is an acute anxiety attack. And that's where the documentation, not only in the ER, but the history and physical, progress notes, and discharge summaries, that's what makes up the case. So when we talk about chest pain, a lot of corollaries are used: acute coronary syndrome, angina, cardiac chest pain, heart attacks, ischemia, MI, unstable angina. A lot of these semantic issues affect payments, and we'll talk about when we move on to some slides about comorbid conditions and how semantics can actually affect payments. There's a lot of resources available not only for providers but for patients, and a lot of patients now read about their symptoms, read about their disease before they even come in. And so American Heart Association has a lot of good information, not only about chest pain but about other cardiac symptoms. The Society of Cardiovascular Patient Care, they have the chest pain center accreditations for hospitals, whether it's 2 beds or 4 beds, and they talk about some data on what to look for. So when we look at chest pain as an initial evaluation, what we're looking at in the emergency room is to risk stratify this patient into low, intermediate, or high risk. And are these symptoms a result of coronary artery disease? Now, once we've established that, what we want to know is, let's make them into risk of low, intermediate, and high for short-term death or non-fatal MI from ACS. Now, the initial evaluation, this is a dynamic, ongoing, risk-oriented evaluation of these low patients, and what you're looking for is, will they convert to a high-risk status? And that's where, the function of the emergency room is. Once they've done that, what we'd like to do is, who do they pass the baton to, whether it's the hospitalist or whether it's the cardiologist. So in the emergency room, some of the best risk stratification tools is as we've learned for many years, history and physical. EKG, now standard EKG or right-sided non-standard EKGs, and again to figure out whether there's an infarct in the anterior or the posterior or circulations. Cardiac biomarkers, so troponin, CKMB, myoglobin. We'll talk about some of these, the uses of troponins versus myoglobins in the future slides. And then a lot of the ER physicians and hospitalists, we have our predictive schemes. Sometimes we can order a non-invasive imaging test in the ER. Sometimes we just have to hospitalize them and do it the next day, again, depending on availability of non-invasive imaging studies. Echocardiogram, exercise testing, and then the technetium stress test that has become standard. Now, what is important is the high-risk features in the emergency room. So when a patient presents, what we want in our documentation, not only from the ER, but even from the nursing staff, the triage staff, the admitting hospitalist, is there an accelerated pattern of angina? Again, these semantics are very important in terms of terminology and predicting value-based care in the future. The duration of ongoing rest pain, signs of congestive heart failure, hemodynamic instability, arrhythmias, new or old, advanced age, because age is a predictor of higher risk for coronary events, and then ischemic EKG changes or elevated cardiac biomarkers. I think what is important is we see a lot of cases where EKGs have not been done or they haven't been interpreted, and diagnosis of ST or versus non-ST has been made. So that's where, when an auditor is looking at an ED note, they want to make sure that the entire panel, the cardiac panel, has been done, has been reported, has been thought of, and the medical decision making coming to that diagnosis has been put out. So when we talk about EKGs, why I have a full slide on EKG is a number of times, whether it's a primary care physician admitting to the hospital for chest pain, EKGs are just not present. And there's a huge red flag for a case that comes in with a chest pain. So EKGs, they carry diagnostic, they carry prognostic values, ST segment and ST elevation, These are the primary EKG markers for an unstable angina. We need to know these because that's where our intensity of service or our consultation or even transfer to a tertiary facility comes. Now, Q waves is an older concept, and that's been replaced with ST segment characteristics. Inverted T waves is suggestive of ischemia, though it is not always associated with an MI, and that's something that the providers need to document. Troponins, these have been around for many years. We know a positive troponin does evaluate myocardial ischemia. What we need to figure out is, are there ST changes to know whether this is an ST elevation MI or a non-ST elevation. But troponin elevations are predictive of MI and death, and they are independent of CKMB levels. So we've done a lot of cases with peer-to-peers where the impression was chest pain. However, troponins were positive either late in the ER stay or early during the hospitalization. However, the history and physical or the progress note for day 1 and followed continued to have medical decision making as chest pain. So if you have symptoms of chest pain, symptoms of angina, and you have positive troponins, you have to go back into the documentation and see whether this is a non-ST elevation MI. And a lot of times what happens is the treatments are being given for non-ST elevation MI, the cardiologist is on, the imaging studies are all ordered, but the documentation still follows a chest pain, right until the discharge, where now they say non-ST elevation, and those are red flags. So troponins are great because they can persist for 7 to 14 days after the initial release. So they take time to raise up, but once they're up, this patient has suffered an event in the last 1 week to 2 weeks. So American College of Cardiology has come out with chest pain scores and high sensitivity troponins for evaluating chest pain patients. And a lot of these algorithms are either part of EMR systems or part of physician documentation improvement activities in the ER. These are available through the hospitalist team. The LMS will have all the links to these articles in case your providers need to go through them. The American College of Cardiology and American College of Radiology, they released imaging guidelines for ED patients with chest pain. So, when do you get a stress test? When do you get an echo? When do you get imaging for chest pain? So these are what we want to stress by showing this is auditors are aware of this evidence-based guideline that's available. And so not doing chest x-rays or doing excessive CT scans, the auditors look at whether this is a good quality care versus whether there's medical justification of doing these procedures. And the whole ordering system is the reason why CMS introduced the value-based purchasing, where they want good value for the money they're spending for the patients. And they want to make sure that hospitals aren't ordering unnecessary tests. So the idea is all the providers, even case managers and physician advisors and hospitalists, the specialists, they need to know that evidence-based guidelines exist for this and that they are being looked at. So what is the documentation to support a diagnosis? So reliance on an H&P only has resulted in 5% of MIs being discharged home. Now, being a provider, a hospitalist for many years myself, chest pain is also the number 1 diagnosis for malpractice claims. And so, you hear a lot about defensive medicine by physicians. Chest pain due to MI is one of the highly missed diagnoses. And so a lot of the ER physicians do not discharge them solely on an H&P. So physical exams, EKGs, CKMBs, troponin levels, these all add to support the diagnosis. Now, documentation points, you need to make sure serial biomarkers are in, serial EKGs are ordered, serial troponins are ordered. the need for continuous EKG monitoring. Someone presenting with chest pain now having atrial fibrillation or SVT, you need to put in your history and physical the need for continuous EKG monitoring or continuous telemetry. Echocardiogram and stress testing orders, that needs to be part of the game plan. And that's where the education of risk stratification comes in. While the patient comes in with chest pain, this patient has diabetes, hypertension, high cholesterol, the workup that you're planning on doing. That needs to be part of the H&P. Now, when we talk about observation, there are some factors that favor observation, and this is for patients with a low probability of disease or risk of adverse events. So, non-traumatic chest pain, stable vital signs, normal cardiac biomarkers, non-diagnostic EKGs, and again, cocaine-induced chest pain. This is just a complete different animal. I did a presentation for the World Health Forum in Geneva a few years ago for cocaine-induced acute coronary syndrome and how it mimics. And so it's a more a vasospastic process than it is an anatomical blockage of the arteries. Now, observation patients, we need to make sure aspirin or some antiplatelet has been put in and cardiac monitoring is ordered. Now, when we when we place patients in an observation level of service, what we're trying to do is, we're trying to rule out non-ST elevation or ST elevation MI. The pain is resolved, and then we do objective cardiac risk assessments. They need to be completed prior to the discharge. Get the outpatient appointments scheduled as you need them, and finally discharge the patient. Opposite spectrum is when do we think this patient is going to be in the hospital as an inpatient. And again, these are based out of some screening tools, but even when we look at the CMS2 midnight rule, if a patient with a high probability of an MI, you have unstable vital signs, blood pressure is 90/50, heart rate's shooting up to 110, 120, or even bradycardic at 30 or 40. There are EKG findings that suggest an acute MI, and you're putting this as an unstable angina. You're putting IV heparin drip, blood pressure control, morphine, oxygen. This patient is going to stay more than 2 midnights, or the severity of illness is high, that you have a high probability or prediction of an MI. So in patients whom you think have a high probability, you want to make sure beta blockers, unless they're bradycardic, calcium channel blockers, aspirin, antiplatelet agents, anticoagulation, and then cardiac monitoring. Now, not all of these, you won't have patients who are going to qualify for all of these, but what you need to do is document, or at least have the providers document, what are the contraindications. Why can we not use aspirin? Why can we not use an antiplatelet agent? So that's what formulates the critical thinking of medical decision making, and auditors want to know that, to know that yes, all these points were thought out. Hospital administrators and coders want to know that, and eventually CMS wants to know that, because they want to know you thought about all this and your patient was sick before they start to pay you the high value dollar amounts. Now, this slide, you can see how do we justify continued stay this is not only for chest pain, but for any diagnosis. So you need to ask these questions: is what's the severity of illness and what's the intensity of service? So what is the condition that can only be treated in an acute care facility? And then follow that up with, hey, what is the treatment that can only be performed in an acute care facility? So simply identifying the disease process is not enough. What you are doing to treat that disease process should also be available only in the hospital setting. When we talk about comorbid conditions or major comorbid conditions, we'll talk about some cardiac ones. And, these are secondary diagnoses that actually tell the reporter on the severity of your patient, mortality, morbidity, length of stay, and utilization of resources. So when we talk about cardiac CCs, you can see there's acute MI, unstable angina, blocks, trifascicular blocks, atrial flutters, CHF. There's hypertension, whether that hypertension is associated with acute encephalopathy, whether there's a post-MI syndrome, what if there is tachycardia, what is the tachycardia? And so that That's where your specificity in your documentation comes in. When we talk about the major complications, you can see acute CHF, systolic or diastolic, something of a patient presenting with encephalopathy with coma, or acute pulmonary embolism causing a chest pain. Other MCCs that actually overlap with patients presenting with chest pain could be acute renal failure, ATN, acute liver failure, metabolic encephalopathies. So a lot of people who have access to the LMS, I know, pause at these slides to look at them, and then try and incorporate them in their documentation points. All right, so terminology, and this is where my talk about semantics in terms of what CMS wants. Simply putting a low hemoglobin of 7 and bleeding per rectum is not enough. You need to put in something like acute blood loss anemia due to hematochezia, or if it's upper GI blood due to upper GI hemorrhage. So specificity in documentation is what CMS is looking at. So angina pectoris, when we talk about HCCs, the number 88 in the Medicare HCC model category, they talk about chest pain and angina. These are not interchangeable for coding. So chest pain is not a risk-adjusted diagnosis because it can be caused by many non-cardiac conditions. What they want is you need to specify the type of angina. So angina that's controlled on medication, should be angina stable on Isordil. So even though you are doing the right thing for the patient is getting well, all the orders are right, what you're writing as simple chest pain is not going to get the risk-adjusted diagnosis as if you were to put angina due to a cocaine vasospasm. So again, specificity is the key word. Now, chest pain as a DRG, hospitals, when we looked at this data, some hospitals with only 20 to 30 beds versus higher tertiary systems with 1,000 beds, they had about 11 to 25,000 discharges a year, and the average reimbursement, depending on what was done and in terms of comorbid conditions, roughly ranged from about $4,000 to $11,000. Now, this is a huge range because variation in documentation does cause this. Now, when ICD-10 came out, they had some really good clinical concepts for cardiology, and these are available free for people on the CMS websites. We have a link to this. It's a 29-page document. But what I'd like to focus on is when ICD-10 came in, they became more specific for chest pain. So just chest discomfort, the R group of 07.89, you can see there's pleural, there's central, there's anterior wall, there's atypical, musculoskeletal, and then when we go down, there's chest pressure, there's chest tightness. My guidance to all providers when I look at it is it's okay to use symptoms when the patient presents, but by the end of day 1 or early day 2, you should know what disease process you are doing. What we don't want is 2 or 3 days into the hospitalization, the progress note of the discharge summary still talks about chest tightness, and you've already determined this is a positive troponins, patient has had a stress test scheduled for an outpatient cath. That is a non-ST elevation or an unstable angina. So the documentation pretty much needs to be looked at on a continuous basis. Now, that's not practically possible all the time, but that's where the entire team comes in. So if someone, the hospitalist or cardiologist, has rounded at 7 a.m., troponins come back positive around 2 o'clock, and the case manager or the nursing staff tells the physician, he says, all right, go ahead, start a heparin drip. Well, now you have a non-ST elevation MI or an unstable angina. Patients continue to having chest pain. So what that requires is one of the providers to come back and then put that as an addendum saying, hey, this is what it is based on these facts, and this is the escalation of treatment that we've done. So principal diagnosis, and this is something, again, it's so important with chest pain because there's just a vast variety of differentials. So it's the condition established after the study to be chiefly responsible for that admission. Now, 2 or more diagnoses can equally meet the definition, but the principal diagnosis is always the reason for admission. So say you have someone with chest pain, non-ST elevation MI, and you also found they have a DVT or leg swelling that you've started. The reason why this patient is in the hospital is for the chest pain, MI, schedule for a cath. The DVT is a diagnosis that needs to be a secondary diagnosis because, one, it doesn't always need a hospitalization. DVTs can be managed on an outpatient basis also. Now, this is one of the cases that CMS has used, and what they talk about is this elderly female presenting with chest pain, and she describes it as mid-sternal tight squeezing pressure, epigastric 5 to 10 minutes. It's a third episode. She does have hypertension, obesity, blood pressure is slightly high at sitting. And what CMS wants us to do is they want us to identify that this subsection of patients is angina pectoris, not simple plain chest pain. And they've given us some ICD-9 conversions to ICD-10 in the diagnosis codes. So simply writing chest pain is not appropriate. You need to put in angina pectoris, essential hypertension, hyperlipidemia, obesity, and then the Z codes of BMI. And a lot of this the coders can do, but they can only pull out from what the physicians documented. So hospital quality reporting, very important for hospital payments. A lot of penalties are coming in for this. So chest pain for reporting for outpatient encounters is aspirin on arrival. So ER departments are held at a standard of someone coming in for chest pain. How soon can they give an aspirin? Was it given? And I know another metric that they look at is median time to EKG. These need to be performed in the ER as soon as possible. I know some targets have 8 minutes, some have 15 minutes, but a 12 lead EKG for an ST elevation needs to be done within 10 minutes. So these are things that are being looked at from a hospital standpoint, as well as quality of care reporting when it goes to the payers. So exceptions, reasons for not administering aspirin is an aspirin allergy. So aspirin is one point that has to be mentioned. Was it given? When was it given? Was it not given? Why was it not given? And so it needs to be part of the documentation by either the physician, the APN, the physician assistant pharmacist, whoever is part of the team. The record needs to be formed. Now, this is a very busy slide, and the idea is not to go through this. But when MACRA MIPS were introduced and are starting in a few months, the American College of Cardiology came out with their own quality reporting measures. And a lot of these measures are what we have just talked about. So aspirin, EKGs, treatments, beta blockers, ACE inhibitors. If if your documentation is rock solid, all these quality reporting measures you're going to pass without any problems. Now, we always come down to all this that's happening. How does it affect physicians? And when the 2 midnight rule came in, it shifted our judgment, our complex medical decision-making judgment, to a time-based definition. And does the care require more than 2 midnights? But what we'd like to do is decision to admit is based on cumulative time spent at the hospital, beginning with the initial outpatient service. And this is what CMS defined with the 2 midnight rule. I think having said all what I said, not only in this presentation, but in the many that we've done, is documentation is critical. And when we talk about this to provider groups, not only through the LMS, through webinars, to open door forums, even our on-site presentations, we say either you adapt or you perish or migrate. And that's the whole goal. Is we need to know the rules of the game, in terms of documentation, in terms of what the payers are asking for, all having providing good quality care and value-based care to the patients. So a lot of the links have been provided on the LMS. People who have it, there's PowerPoint. The whole PowerPoint presentation will be uploaded by the end of the day.
I have a question. This is Dr. Chada. Can you comment on the chest pain order set?
Sure. So a lot of the hospitals have chest pain order sets, and these are either in the paper sets or in the EHR, where all these orders are standard set orders, and a lot of the hospitalists, a lot of the cardiologists use those. But there is one caveat, and one important thing we need to know is those need to be signed and dated before they become real orders. So simply having a nurse pull out a chest pain order set, putting into the patient's chart, when the provider has not reviewed it, signed it, made his initials on it, those are not valid. They need to be authenticated before they become real orders. But I think this is the way to go on having order sets. Those are guidance to the providers that they don't need to remember all these orders for different diseases. All right, so I have a question that's come to me on the chat about a stress testing. So a lot of the hospitals have 24/7 stress test capability. Now that is a rarity rather than a norm, because about half the hospitals in the country are rural hospitals, and their stress labs are usually open Monday to Friday. Some have them open half day on a Saturday, but I know very few that can actually afford keeping a stress lab open on a Sunday. And so a lot of times with the 2 midnight rule or medical necessity, if we're not doing anything for someone on a Saturday afternoon or Sunday, and we're just waiting for them to be on to have a stress test on Monday, that's where those red flags start coming in. Now, a lot of centers have these chest pain units in the ER, where the ER can actually do a risk stratification and then do the stress test, and then if it's positive, decide whether they need a cath, they need cardiology or hospitalist, or if it's negative, and they can send this patient home without patient follow-up. But again, the use of the stress test, again, an expensive CMS cost, and they're looking at whether the orders were placed or the procedure was done due to a facility or provider convenience, or was there actual medical necessity for delaying the test. All right, I have any other questions from the group? I have one that I got on an email. All right, let's do this. So, decision to admit to hospitalist versus cardiologist. All right, so I've been a hospitalist for many years. Our group and hospital policy was anything but a ST elevation MI came to the hospitalist team. All the ST elevation MIs went to cardiology. And that seemed to work out because, if there's such a huge differential for chest pain, and if it's a non-ST elevation with other ongoing diseases, the hospitalist could coordinate care better. But if it was ST elevation requiring aggressive therapy and antiplatelet infusions and CATs and cardiothoracic surgery consultation, cardiology was more comfortable taking those.